Welcome to Broad Eye, the podcast that explores knowledge gaps in ophthalmology and eye care. So hello everyone and welcome to another episode of the podcast. My name is Sean Maloney and today I am virtually sitting with, like usual, with Dr. Natalia Villa. So Natalia, welcome to the show.
Hi, Sean. Thank you for inviting me.
It's so funny to say like I'm welcoming you to the show because we've worked together over the years and become friends, and now I'm saying, hey, come and join the podcast, and have to be so professional, right? But it's we'll try to keep it just like as two colleagues chit chatting and stuff too, and I think there'll be some interesting stuff that will come out of it. So, can you just give a very brief summary of who you are and what you do? I can give a little prelude there. You're a retina specialist, but maybe just talk a little bit about how you got to where you are and what exactly your job involves.
Okay, yeah. Well, first of all, I'd just like to thank you. I think I'm super excited to be part of this podcast with you. And I feel that we did have so many conversations like the one we're having right now that once in a while we would have the opportunity to share. So I think it's actually really fun that we can share that with other people, because that's something that we would actually do. I think I would like to introduce myself saying that I'm a doctor, I'm an eye doctor, I'm a retina specialist, which is a super specialty in ophthalmology, and I specifically do retina surgery, which is to explain that it's the surgery at the back of the eye. So my background, I am from Spain, so I did part of my training in Spain. Then I completed my training in Canada. Then I had the opportunity to work in the UK, so I've been in different places, and now I'm currently working in Canada. And I think we met at the moment that I was actually doing some basic science research. And that's when we actually had the opportunity to work together, which is something also on my background that I've been always interested in and try to combine both things. So I have there's a clinical side of my work and the research side as well.
So, but as a retina surgeon, like what are the more common types of surgery you would do?
In retina surgery, so again, the retina is at the back of the eye, it's inside the eye. So anything that's going on there, you have to go in the eye. So retina surgery, it's we operate with a microscope, so we go inside the eye, and then if there is any bleeding, any trauma, anything that's going on there, or retinal detachment, we would fix that. So it's a posterior approach to be able to heal anything going on in the eye. I'm trying to simplify that, but one of the surgeries that we do most commonly, it's called vitrectomy, and basically it means that we are working with very, very small instruments inside the eye.
Fair enough. Mm-hmm. No, that's a fair description. So you had mentioned that you worked in Spain and then Canada and then the UK and then Canada again. And who knows where next, right? But
you never know.
You never know. Did you come across any differences, I guess, in how medicine, or maybe more specifically ophthalmology, is practiced in different countries, or even in different centers within the same country?
That's a good question. It is different, right? I think I was fortunate enough to work in developed countries, and every single country had universal healthcare, meaning that was a system that the population would have free access to healthcare. So I think that I was lucky or always interested in working in this type of medicine, and the three places I work actually would offer that, which changes completely if you would be working in a country that it's private practice. So here, despite having this universal care, also it's very different, right? So there are, part of the logistics regulations that are different in each country. So that makes a difference on the access that you would have some certain medications, how fast you would get that, and what you can offer. So obviously it's different, but it's different also the culture and the patients that you're treating. right? So I always found this very interesting because it's different, the dynamics that you may have with the patient as well. And I think an important factor is also the culture here. In Canada, for example, I think the Canadian patients and French Canadian patients are especially really nice people. So it's really pleasant to work with them, or to have the opportunity to take care of them. And maybe one of the reasons is that US, it's the neighbors, and they know that crossing the border, maybe the access it's not so easy. So then it's a nice, I think it's a nice relationship with the patient, and it's interesting to see that, right? Which is a little bit different what it would be probably in the UK or would be in Spain. So yeah, answering your question, I think it's quite different. Even each country has different protocols and do things completely different, and things that would not be completely allowed in a place are completely normal in another place, which it's a good exercise for yourself, right? To reflect on medicine and what's practice, good practice. So at least I think being exposed to different things, it gives you a different perspective as a doctor, and for me, it's been actually a very interesting process.
It probably just helps you develop that skill set and working in different teams, right? It's like you said, different people with different training backgrounds, or were trained in different ways for the same career path. So it probably just makes you, when you're working in that environment, I imagine as a surgeon, of course, you have to be very technically skilled, but you probably have to have, how do I say, whether it's leadership skills or, being able to work in a team dynamic and working with diverse people. I'm sure that alone is a skill that needs to be developed as well to have a successful surgical team, right?
Yes, I think it's for sure key for success, right? You're working in a team, and that's every time you sign a new hospital. Actually, it can be in different countries, but a hospital is like a small town. It's like I think I always have that impression when I sign a new place, because there are certain dynamics that are always the same, but there's a lot of people working there. At least in my case as a surgeon, you will have interactions with nurses in the operating room, with the anesthetists in the operating room. So when you start in a new place, right, it's when starting from zero and understanding how things work there, what's the culture in that hospital, how you can fit in, and then ultimately, right, you want to work in a way that it's effective, that it's for good care, and that means to have a good team, right, or work together in a good team. And that sometimes it can take some time. When you're starting in a new country, I found completely different the way I would interact with the nurses in the UK, or the way that I would interact with the nurses here, So it's you need to learn that part as well. And I think it's you have to build that skill set in order to be able to do what you really have to do, which is take care of the patient, right? So it's a different part to also learn how to take care and practice medicine, because at the end, all these interactions are equally important to succeed, right? It's for me, it's been very interesting actually to see you are more observant at the beginning, just trying to understand. And then I think once you've done it once, it becomes easier the second time, right? So every time you sign a different hospital, then you already know some sort of patterns, some sort of ways to work. So then you learn much faster.
Okay, so I want to just, whether I don't know if you're comfortable talking about it or not, but when you said how you deal with nurses in the UK versus nurses in Canada, do you have any specific examples, or do you not want to go down that road? I'm just curious. It's very, ominous, I guess, when you're saying it. I'm curious if there's anything specific that comes to mind and how those interactions are different.
Yeah, I'm trying to think. Other than in the UK, they have a lot of tea all the time, and they stopped to have tea and cookies, which I respect. That was good. But I think that, for example, the protocols there are totally different, right? So here, I always felt that it was more efficient. It's a very efficient way. So since the very time I started, I think that the nurses were, very efficient. In the UK, the protocols they're very strict sometimes. So it would change the complete dynamic in an operating room, right? In a way that I always found it was quite different. So I guess that I think here probably you are able to organize your operating room in a different way, or I got to organize this in a way that you can decide how you do it. UK, it's more strict with certain protocols. I don't know how to explain. I think that at the end, there's some mentalities that are more conservative, some mentalities that are more open. Here, I always found it easier in a way. They were open to the change, to adapt to the way that you would be working and things like that. If
No,
that answers your question.
Yeah, no, I think so.
I wouldn't say it doesn't anything specific comes to mind other than something that was shocking to me at the beginning when I was working in a clinic there. They would bring me tea and cookies, which I thought it was really cute. Yeah. Yes, exactly.
That's
so
amazing.
It was very important there, you know.
Here is just coffee, but no
coffee.
Cookies.
Yeah,
so that's it.
Yes.
Coffee and more coffee.
Yes.
So you talk about protocols. You had the opportunity to work in both UK and Canada during COVID. How has COVID changed or impacted in any way your work environments, whether in the UK or Canada or both?
I think it would not be fair to compare because UK was the first wave and Canada, I was here for the second wave, right? So we all learned from the first time. So I think the second time, everybody was more ready. But UK, I don't think it has been an example to follow in some respects. And the beginning, I think, was a bit of it was a challenge everywhere. I don't think it was a country that, for sure, some countries deal much better with it, but UK was a challenging time for everybody. Not, doesn't matter if you were an ophthalmologist or any person working in the hospital. We had to deal with the unknown, the uncertainty, the fear of not knowing what's going on, and then depending on certain decisions that would have a direct impact, and we're not knowing what was going on, right? So there was some fear there. Here, it was so much easier, right? We already learned from it, so it was a different way to deal with it. So I think that was the experience I had, but I would find it challenging anyways. It means that things are changing all the time, that you had to adapt, you had to be ready for any change anytime in a way that would have an impact on clinical activities, and not only for the COVID patients, that obviously that was a priority to take care of those patients, but there were many other patients that they needed care as well, right? That's the other side of it. It's like, it doesn't stop. The patients that they have problems, it did not take a break because it was COVID, right? That still happens. So then I think as a physician, you are also dealing with that, seeing that you would like to be offering care to all these patients. And it was very difficult here and there, right? I think it doesn't matter where you were. I think that was quite universal, right? Priorities were clear, and other things were difficult to be taken care of.
Well, I think that one thing that stood out or stands out from our conversations back in the spring, whenever things were really just kind of blowing up in terms of caseloads over in the UK, one of the things that stands out in my memory is how you were indicating, like, as a doctor, and most doctors seem to be stepping up and willing to, be put on COVID wards, for example, even as an ophthalmologist, to help these patients, and certainly willing. But even in the face of all that, it seemed like, medical supplies like PPE was not available in some cases. So it's like, I remember these conversations where we're saying, hey, it's like, I'm a doctor, I have a duty to assist patients, and I will, but like, there's a shortage of N95 masks and other protective gear. And it's like, you can't be going in dealing with these COVID patients and then going back to the ophthalmology clinic and seeing 100 patients a day. Like, it's just, it was a lot of, it seemed like there was a lot of fear and confusion and back then, and I guess it's now.
Yes.
When you're going through the second wave here, I guess there's you didn't have the exact same problems, right?
Exactly. We didn't have to deal with that, so that was not a problem. But back in the UK, that was not the only place that they struggled to have the PPE, right? But it was it was a moment of, I think, as you said, confusion, probably, because you still need to keep doing things. And I as an ophthalmologist, I was not working in ICU, but still 50% of my department was redeployed to a palliative care in COVID, right? So everybody had to be ready to do whatever it takes to the circumstances. And we never had that experience before, right? Or we were not completely ready for it. I think even if you're ready for certain things as a doctor, or you had to deal with emergencies and you've done calls, but we were not ready for something like this. And I think some people had to really step up more than others. But we all had that experience of, I'm going to work, and I had to buy a mask in Amazon because I don't know what to do, right? I don't know what I'm going to find that day. And at the end of the day, you have to do something. So it was, it was something we all look back and learn from a lot of things. But I think that the uncertainty and the fear was mostly the first thing it comes to mind at that moment.
Yeah, and I think that it must have been difficult, as when you specialize and subspecialize, and you spent however many years doing that, beyond the basic medical school training, to then find yourself, not you specifically, but just generally doctors who are redeployed to emergency care or palliative care for COVID patients. It's almost like you might have been 10 and 15, 20, 25 years for some doctors out of general doing that in medical school, for example. And now it's like you're shoved back into that and saying, here, you're a doctor, do this. It's like, well, I'm an ophthalmologist or I'm a dermatologist, I'm not a palliative care doctor, right? So that must have been difficult, I guess, to navigate for people who had to do that.
Yeah, absolutely. I think that for sure it's easy to say, you were trained on that and you have the knowledge and you should have certain skills, but you probably have spent more time doing your specialty that has nothing to do with all this than the time that you actually you had some training on those basic skills, right? Or different type of set of skills. So it's really hard, because at the end it's really hard in terms to you want to provide the best care possible, right? And then suddenly you have to know certain things that you really don't know, or you never managed, right? Or you never really were a doctor that needed the skills of being in an ICU or things like that. So you feel your responsibility, and it's try to do it, and you want to do it, but obviously that was a bit of a challenge for a lot of people. For a lot of people, I think that everybody wants to step up and do what it takes, but it comes with a lot of things to be able to do that, and it was definitely not easy for a lot of people. But you also saw a lot of kindness, a lot of good intentions, and they keep saying the same thing, we're all in the same boat. Yeah, sure, it was like that, but and you saw a lot of I would say kindness also around these gestures, not only in medicine, right? Or not only in at the hospital specifically. It's a lot of people try to help, a lot of people try to do a lot of things those days, which was actually it made you feel good as well, right? It's you are the one who kind of have the skills to do something, but everybody else was also trying to do something about it.
It's tough. I think, I talked with you and other friends who are physicians and different specialties. And I think that the general public doesn't always hear the stories of physicians, for example. So in this case, you having to, or a number of people in your department having to be redeployed to a palliative care unit, and just what that meant for them, and a lack of PPE, and fears. I'm sure there was a lot of emotion running through the
Yes,
teams of
I
people who
think
are being redeployed, and fear for maybe I'm an ophthalmologist, and my mother lives with me who needs some care, and I'm taking care of that person. And now I'm saying, now you're going to work in palliative care with COVID patients, saying,
yeah.
well, and you don't hear some of these stories. What you hear is, such and such a hospital has, redeployed whatever 25 physicians from different departments to help tackle the caseload. And it's like, wow, way to go, hospital, which is great, but you don't hear the other side of that from the physicians, and how much it was a struggle for many people, right?
Yes. Yes, I think it was very intense. It was very, very intense. It's like not only what we were all seeing at the news, you were hearing that, 24/7, true or not true, but the information that you were receiving was massive, right, all the time. Then trying to keep up or understanding something as a doctor with papers, with information, it was crazy to be able to even understand all that. And then the personal experience, and also for sure the stress that was causing in the individual itself, but also the family around it, right? It's suddenly, it's not only you, right? There are many people that were also having a problem. Well, I think there was a lot in the media also showing that, right? The stress that would cause in a family as well. And some people would not see, even this living in a different place. They were offering some sort of hotels in my hospital. They were offering hotel rooms to stay there. Childcare. It's like all these arrangements to be able to do that even safely. I'm not even sure it was safe at the beginning, right? We didn't even know, but yes, it was very intense for many people.
So I'm going to switch to something a little more fun. So, we can talk COVID, and I know you and I have exchanged a lot of stories over time, over this past year. You told me a fun story once. I don't remember the entire story here, but maybe you can share with people who are listening. And it had to do with John Lennon's sister. So that's the key. Can you tell that story?
Yes. So I did work in Liverpool, and that was my experience in the UK. And I guess, we all know something about Liverpool, and that the Beatles come from there, right? So you will hear the music all day long when you're there. And my experience there was, I was in a clinic one day, and I remember finishing the clinic, and then suddenly I've never seen so much security in the ophthalmology clinic. And I see, chief of the department, I start seeing a lot of people and a lot of security, and it's like, what's going on, right? So you don't know exactly what happened, and all was around a box that had inside John Lennon glasses, right? Which I thought it was well, I did not expect that. And the one who was there was actually John Lennon's sister, who for some reason they needed to check something about the eyeglasses that he had in our department. So I would never have imagined that an eyeglasses would have the amount of security around that. I thought something major was going on at the hospital that I don't know. But yeah, so that's what happens in Liverpool. It's real, they exist, right? So you see that it's the Beatles town, but it's true. Things like that happen. So I thought it was a cool experience. Yeah.
Just wonder what would I guess what were people looking for if it was his sister? What are they trying to understand about his glasses? I guess I don't know. I guess if if you're the Beatles, I mean, everything's special, I guess, right? Your running shoes, your glasses, the coffee mug you drank out of, I don't know.
I don't remember. I think somebody told me the price of those glasses. I don't remember. I don't even want to remember, but that was something absolutely crazy. And I think no, I think they just wanted to document exactly the prescription of the eyeglasses, right? So you can actually do that. So you would know if the refractive error that John Lennon had. So that's a way, an indirect way to know, right? If he was a myop, hyperop, or any refractive error that he had. That's why he was wearing glasses, right? So for some reason they needed to check that or wanted to check that, or I don't know the specifics or the details, but they decided to do that that day.
Well, that's funny. It's an interesting story. So it's just still kind of, you got to wonder why. What's the reason
I don't know.
behind this? Right? This is so.
I don't know who wanted to pay so many millions many millions for that. They needed to make sure that the prescription was right. Who knows? If you want to sell it, you need to make sure what you got.
Fair, I guess.
No.
Okay, so I wanted to switch gears a little here again to talking about. Let's start with the company you were working with called Ibionic. Can you give a little, just a very brief background of what the company was working on, how you got involved, what their vision was, and what ultimately happened with the company?
Yes, sure. So I did collaborate with Ibionics. Ibionics was a company who developed a very cool, interesting technology for bionic technology in order to treat patients with RP and also macular degeneration or retinal conditions. That company was created a few years ago, and there was a lot of research done in Australia. And here, the University of Montreal, they were in charge to develop the surgical technique to be able to implant this technology in patients. So I was fortunate to be invited to collaborate in this project. And I did collaborate with them for about a year. So basically my job was to work in trying to develop the surgical technique to implant this technology. And that was a team at the University of Montreal in charge of that. We work with an engineer as well, so it's a different team working with that, a big team actually. And I think we did a great job. We think it was a fascinating project to me in order to be able to understand, the technology that they developed to be able to implant that and make it possible. And I think that was actually very exciting and a good challenge. And there was a lot of efforts. I think the progress was really, really good. It was very, very promising. Unfortunately, sometimes the market, it's more complicated than that. And for me, that was something probably new. I think my background as a clinician, you are not used to it. And I think despite it was a very interesting solution, it was a very interesting technology, and we did work really hard to be able to implant that in patients, was not the main interest in the market. And despite some patients probably would benefit from it, now probably the research is moving towards different directions, and unfortunately the project stopped. So I don't think we'll see that in patients ever. I'm not sure if that's going to change in the future, but at this moment, there's a lot of research being done. There is a lot of efforts, a lot of investments already, but that never really was available in the market.
It's interesting, and it's also frustrating, right? So I remember you had put me in touch with I think it was Suzanne, right, who was the CEO of the company.
Yeah, the CEO of the company.
Yeah, and there was another guy, I forget his name offhand, but and actually I had they gave me their pitch sheet, I guess, because they were trying to do some fundraising, because I know a few people who are venture capitalists in this domain are investing in some med tech technologies, and I tried to put this in front of them because I personally benefit from this type of technology being implanted in patients as a patient with retinitis pigmentosa. So and then I remember hearing that the company well, Suzanne had indicated the company needed to raise, it wasn't that much. It was like, $250,000 or $300,000 just to continue on for the next 6 months or something. And eventually it just dried up, and it sounded like such a promising technology. I mean, I'm not an expert in evaluating how promising some technologies are, but just from what I knew about it and from speaking with you and others involved in the project, it seemed like it had a lot of potential. And correct me if I'm wrong, but one of the main engineers behind this technology was the guy who was involved with developing cochlear implants.
Exactly.
Correct?
Yes,
Yeah.
that's correct.
So it's an experience of just taking a device right through to market and becoming, massively available. So it seemed like there was an all-star team behind this, and the technology was solid, and funding just wasn't there. And it just seemed like, as a patient, that's frustrating, because you think, oh, we're just waiting for a company or researchers to develop this
yes.
fantastic device or medicine or something. And some of these might have actually been developed and have just gone by the wayside already, that people could have benefited from. And it's something I don't think a lot of patients realize. Yeah. And as a patient, it's hugely frustrating when you hear these things.
Yes.
So to think that maybe there's technologies that could be helping, for example, someone in my stage of blindness, right?
Yeah.
And but I think it's important for people to recognize that. I mean, all this. Yeah, go ahead.
No, I think that we have now the perfect example to understand that. The whole world, in the middle of the pandemic, and suddenly everybody understands that research is really important, because we need a vaccine, right? We all need a vaccine. We are all living that. So all the efforts are put into that, right? And it happened, right? Did it happen? It would be insane, right, to think that something could happen. I think quickly, if you think about it, if we would put all the same efforts, right, in every single thing that it's needed, it would happen as well, right? So unfortunately, all these efforts are not put it all the time in every single thing. And as you said, I'm sure for me, was no question that technology would help patients. And there's, there are different stages of the disease, there are different type of disease, there are many things, right? But there's for sure patients that will benefit from it. It is true that nowadays, probably the market, it's moving towards different type of treatments, right? We were talking about different genetic treatments. So it is true that it's all evolving towards that, but we are not there. There's a lot of work to do. There's still some research going on. We'll see how much effort it's put into that too, right? We'll see how long it's going to take. But all these patients that are already waiting, right? They may not make it to it. They may not make it to these new technologies that maybe are going to save certain conditions, are going to treat certain conditions. So there's still, something that you could be offering today that we are not because there is not research, no efforts, brilliant minds. And honestly, that there was a lot of good work done with that project, right? But we won't see that, right? Unfortunately, there were not probably the right investor at the right moment, or it did not happen. So I think it's very frustrating, right? So as a patient, I think, well, just talking to you right now, obviously I can understand that it's even worse, right? To hear when it's something specific that you think that maybe you would benefit from it. It's the difference. There are different sides of the research. It's not only what it's the researcher or the university itself or all the people involved think that it's going to be useful, and it is useful, and there is a lot of efforts and a lot of brains that have been working on that. Then there's the second step of it, right, that needs to make it to the market, and there are many other things that play a role there. And that's for me. I have also. It's also frustrating, for me, even if it's not as a patient, it's also as a physician, thinking that you could be helping people and you're not. Right? You could be offering people and you're not offering that, and it exists. It should be available, right? So I'm sure that translates to many research, and I think it's one of the hardest part in this field, actually. I think you probably live that as well. It's like so hard. It's really hard to do research. It's really hard to have results. It's really hard that you have the funding to progress. You have the, you have the resources to be able to make it happen. And then the last step, it doesn't happen for something. It doesn't seem that, relevant, or it is probably, right? It's you want to sell something in a market. Mm-hmm. But if you think, even if you are the patient, even if it just helped one patient, it's worth it, right? That's how you as a healthcare professional or a researcher, that's how you want to think.
Of course, it's not. We all know that part's not that simple. But on the note of just technologies and seeing where they can and can't go and market need, you and some of your colleagues have patented a surgical device, correct?
Correct. Yeah.
So now you've seen the need room. You've gone ahead and gone through navigated the engineering and or patenting this technology or this surgical instrument. But now, is that something everybody's using now, or is that something that is just intellectual property that still needs like millions of dollars to develop? Now, I already know the answer to this, but I'm throwing that question at you, maybe to if you want to unpack that one a little bit.
I think it's so for me, again, I am a clinician, and I did not have experience with this part of the other side of the project, or in this case the surgical device. It's so much work, it takes so much effort, and I think it's really hard. It's like you feel that, yeah, that's a no-brainer, that's just going to help people. It's you put all the efforts, you want to do it. Maybe that's the naive version that you're having, but then only going through that process, it's really, really hard. And there are so many other factors, right, that you don't really know well, but that's how probably the market works, right? And then it takes more efforts, and well, it's a totally different wall. It's a different wall, right? I feel that there's a huge gap to what the researcher, clinician, or health professional sees and envisions, that there's a clear benefit to get to that point, right? There's a big gap. And maybe in my case, I did not have much experience in that, but learning now a little bit more, it's a very complicated process, right? So it takes a lot to make all these things happen, right? So probably, again, going back to the vaccine, right? If there are other efforts and helps, and it would probably help many other things, right? I think we end up probably talking about funding or investments, right? And I think in research that should be key for progress. If you don't have that, it's quite limited. It's really difficult.
Oh, for sure. And so in some cases, it's not a lack of invention. It's a lack of I taking the invention and commercializing it in a manner. I mean, I understand you can't just commercialize something for billions of dollars to help 10 patients. I understand that side of it too, right? But I mean, it's just interesting for people to understand that, right? So in talking about, I'm going to wrap up here with a topic, if you don't mind, but I was going to bring up the concept of artificial intelligence, but then move into the idea of working in 3D. But just to comment on artificial intelligence and talk about some companies, I was reading recently about an ophthalmology tech company, a small, they're about a $50 or $75 million company, so they're not that small, but they have created some software that is going to help diagnose certain conditions like diabetic retinopathy and track the progression of the disease using AI and imaging. And I think that the eye is a very unique organ. Maybe the only other one would be the skin, I guess, which is something that you can see very visibly as well.
Exactly.
But, and use these types of take advantage of AI and advancing computer vision software and these technologies to help in making consistent and accurate diagnoses, tracking how a disease progresses, etc. Have you seen this type of thing in the clinic yet, or are you still? Is it still something that's not being widely used, but maybe slowly being adopted?
I think the places that they're currently using, it's mostly for research at the moment. So it's not something that you already have at the clinic. But I think we're living a fascinating moment with all this. As you said, ophthalmology, it's quite unique because we do have access, or the way that we can examine the patient, let's say, and acquire imaging. It's relatively easy. It's much harder to get the picture from the lungs, right? So with the eye, we do have direct access to it. So that allows us to have very good imaging. We work a lot with imaging. It's a specialty also. We use a lot of technology. So I think we are in a very particular position to benefit from this, and it's already happening, right? As you said, using this technology for a screening process like diabetic retinopathy and many other things. It's actually really, really fascinating. If you take all the specialists in the world to look inside the eye and tell if that eye, not knowing where the eye is coming from, and you look inside the eye, you don't know if that eye is from a male or a female. You cannot tell. Okay, there's no retina specialist that can tell you that. But the artificial intelligence can do that. They can just say it. Yes, it's we don't know why, right? So there are things like that. It's already happening. That things that we were not capable, right, to even know, that suddenly you have this piece of information, or you need to validate that. There's a lot of work to do, but there's a clear benefit already with all this imaging that we have access, that you can apply artificial intelligence and suddenly be a much better tool for screening, for detecting disease. And I think it's just changing so fast. And well, it's not only artificial intelligence, the technology we're using, it's changing quite a bit as well in surgery. We are operating with 3D systems. It's a very interesting era, I think, for us as a physician, and for sure in ophthalmology, it's quite unique.
Can you just talk, just kind of, before we wrap it up, just talk a little bit about what it means now operating in 3D?
So to operate in the eye, you need to see inside. So to see inside, we would usually use a microscope. And now, instead of using that microscope, we have a heads-up display, meaning there's a high resolution, huge screen where I'm seeing what's inside the eye on that screen in 3D. So the image is so much better that allows you to actually play with the technology itself, meaning there are different sort of filters. There are many things that you can do with technology that I would not be able to do with the microscope itself, right? So it's improving the imaging that you're having while you're doing surgery, and offering extra settings to even change the way you're operating. You can apply even some sort of scans that you can see in the same screen. The technology has evolved so much that the information we're having even now during a surgery, which is in 3D, compared to the microscope alone, it's a game changer. Actually, you know, we do have this feeling now that things are definitely changing.
Soon you're going to get replaced as a surgeon, right?
Maybe. Well, it does exist already. There is robotic surgery, you know, in other specialties. It's something very common, but in ophthalmology as well, they started. There are certain things that are going to, I think, are going to be a bit hard in ophthalmology, but it already exists, you know, even for these new genetic treatments that they need to be delivered in the eye. Now robotic surgery can do it, maybe safer. You know, it's happening. It's definitely happening. So
you're going to become a teacher.
Next time, yeah, exactly.
Teach the residents, and that's it. Yeah.
Next time we talk, maybe I don't have a job anymore. You know, it's definitely changing. It's happening.
I don't think it'll happen that fast, because I'm sure we'll talk soon. but no, I think it's a good point. But listen, I have about 40 to 50 more hours of questions for you, which is typical. And I think there's a lot of conversation we've had in the past that would be great topics to bring up on the podcast that just people would enjoy hearing. You have a lot of experience as a researcher, as a clinician, working in a lot of different places, doing volunteer work elsewhere as a doctor. We didn't even dive into that. There's so much that we can kind of explore and unpack, but we can save that for some future episodes. So I just wanted to take a moment to thank you for getting involved and sharing your stories with everybody listening. And I just wanted to thank you.
No, thank you for having me. It's been a pleasure, and I would definitely happy to do it again.
All right. Thank you.
Thank you.
And that concludes today's episode of the Broad Eye Podcast. If you enjoyed this episode, please be sure to subscribe on your favorite podcast platform. Of course, ratings and reviews are always welcome. And you can certainly share this episode with any of your colleagues or friends who might enjoy it. Thanks for listening.